All right. So welcome to our neurotrauma speaker series. I'm Patrick Reed. I'm a neurosurgeon at Mount Sinai. And I'm here to introduce Zach Hickman, one of the city and states and indeed country's preeminent neurotraumatologists. He's currently the chief over at Elmhurst Hospital. He graduated from medical school in British Columbia and then completed his residency training at Columbia University here in New York in 2014. He then did a fellowship with Ross Bullock down in Miami. And then for the last decade or so, he's been heading up the trauma service over at Elmhurst, which is one of the major trauma centers here in New York City. He's going to be talking to us today about traumatic brain injury in the elderly. And so I will cede the floor, Dr. Hickman. Thanks for joining us.
Thank you, Patrick. Appreciate it. Let me just share my screen here. Let's do this. Let me know if I can ever tell. You're seeing the full slide right now, the presenter view.
Full slide.
Okay, great. All right, so thanks everyone. It's been a little bit since we had our last neurotrauma conference, so we thought we'd get it going again and discuss a topic that is rapidly becoming more and more relevant as the population of the United States and other high-income countries around the world is rapidly aging. So we're going to be talking about traumatic brain injury in the elderly, and I realize that in many circles now the term elderly is also kind of a faux pas. So it should be really traumatic brain injury in older adults. And this is obviously a very large topic. I mean, you could talk for hours on this. So we're just kind of trying to highlight some of the key points in this patient population and some of the differences from younger adults and some of the challenges in this population. So no financial disclosures, just a kind of a brief summary of the topics that we'll be going over. So a little bit about the epidemiology and burden of TBI in the elderly and why we're even talking about this. And thought I'd start with this slide because this came out about 6 months ago from the National Academies of Sciences, Engineering, and Medicine. They had a workshop where, I've highlighted 3 of our other Mount Sinai or former Mount Sinai colleagues, Kristen Dams-O'Connor, who's in the Department of Rehab and in the Friedman Brain Institute, and is a preeminent researcher in TBI and the sequela of TBI, and Dr. Dangyach, who's associate professor at Mount Sinai and in neurointensive care, and Ernest Bartholomew, Dr. Bartholomew, who's the chief of neurosurgery at SUNY Downstate and is a former resident at Mount Sinai. But basically, this workshop looked at the large unmet need of addressing research in patients with traumatic brain injury. And there's many takeaways from this workshop. I've just highlighted a few of them here, but and we'll kind of touch on a lot of these. But some of the takeaways are that we often think of older patients in any disease state, and in particularly TBI, is doing more poorly than those that are younger in terms of their outcomes, and that's not necessarily the case. I'll present some data. The data is kind of conflicting a little bit, but probably what we need to really start focusing on this age group, both in this age group and in patients that just tend to have lots of comorbidities, is really patients' pre-injury cognitive status and frailty, and that is probably a larger driver of their outcome than just their age. Age is just kind of a number when it comes to treating these patients. Also, the research, again, this was for addressing unmet research needs. Research really doesn't represent this patient population very well, because a lot of studies have age cutoffs where they might not include these patients, or they may exclude patients that have pre-existing cognitive or other neurological injuries. And obviously that then you're really then winnowing down the patient population that those studies really apply to. And it's not really pragmatic or real world data, and doesn't really represent the disease burden that these patients may have before their traumatic brain injury. So, we kind of need to start focusing trials on this age group and identifying different strategies to treat traumatic brain injury in older adults. So again, I always like to put up this slide because we talk a lot about brain cancer and how many patients have brain cancer and the research that goes into that. And if you look at the number of, say, glioblastomas per year, it's like 13,000, 10,000 deaths. And then if you look at the number of strokes per year in the United States, it's about a million. There's over a million, almost 2 million now, traumatic brain injuries per year in the United States. Of those, almost 300,000 patients are hospitalized. There's almost 70,000 TBI-related deaths in 2021. So traumatic brain injury as a disease burden in the United States and other countries around the world, and it impacts lower and middle income countries, even more than higher income countries often, is quite large, obviously, and costs a lot of money, and there's a lot of patients living with the sequelae of TBI as well. It's important to realize that 1/3 of all injury-related deaths are caused by TBI, and the top cause of TBI in most high-income countries now is falls. It's surpassed motor vehicles, and largely that is due to two factors. One is improved road safety, seatbelts, airbags, things like that. But then even more is that as the population ages, falls become a more common cause of traumatic brain injury. So we used to always think about traumatic brain injury really as a disease of younger people, patients in their 20s and their 30s, males doing high risk activities in particular. But really TBI now is predominantly a disease of older people. There's not only increasing incidence and prevalence of elderly patients with TBI, but patients 65 or older are about 15% of the United States population, but comprise almost half of TBI-related hospitalizations and about 1/3 of TBI-related deaths. It's the largest and fastest growing group of TBI patients. And again, I mentioned the most common etiology is fall. What's interesting, when I ran across this stat, I thought that was pretty amazing, is that more than 50%, so the majority of patients that are now admitted to a hospital for an acute subdural hematoma are 80 years old, which almost seems unbelievable. But when you think about it, think about how many of these patients you're seeing that are coming in with mild TBI and a little, acute subdural, things like that. There's always 60,000 chronic subdural hematomas in the United States by 2030. So this is predicted that it'll be, in the next 5 years, there'll be 60,000 patients with chronic subdural hematomas, and that it will be the most common neurosurgical disease that we treat as neurosurgeons. Center TBI, which is a European longitudinal study that is kind of the corollary to track TBI, which is here in the United States, has shown that now the median TBI age is 50 years old. It used to be in the 30s, and over a quarter of patients are older than 65, and 20% are on some sort of anticoagulation or antiplatelet medication. So, this is just to show that, looking at TBI in older patients, in older population, older patients is, not kind of a niche thing anymore. This is really the patient population that currently comprises the largest group of patients in TBI, and it's only going to get more represented in that disease. So this is just some schematics showing that the number of patients has increased and the proportion of patients that are older than 65 has increased. And when you look at both hospital discharges and deaths from TBI, deaths kind of increase as you increase in age. And then hospital discharges, really younger people, pediatric patients, and then older patients comprise the largest groups. This is just showing that even over a small kind of range of years, over 7 years, you can see that the median age of TBI patients is slowly and steadily marching upwards. Just in those 7 years, there was over a 4-year increase in the age of the average TBI patient. What's interesting is that older patients tend to have a higher GCS, so a better GCS than a younger patients with the same sort of injury seen on a CT scan. So oftentimes patients with that are older patients, that the GCS actually underrepresents the degree of injury that they have after a TBI. And we'll get into that a little bit more. As I mentioned, most common mechanism in older patients are falls causing TBIs. And there's an increasing incidence, as I mentioned, of acute subdural hematoma in elderly patients. So we'll kind of shift and talk a little bit about outcomes after TBI. So I mentioned, the data here is kind of conflicting. So there is, data to support the fact that overall in-hospital mortality and outcomes tend to be worse in the elderly population. The real question is why? Is it from the TBI or is it from something else? So if you look at the elderly population, overall in-hospital mortality is about 16%. The major contributor to that is really patients with severe TBI, and then to a lesser extent, moderate TBI. Older patients that have a mild TBI tend to do quite well, actually. As you can see, there is an increased mortality with age. Patients that are older than 70 years and older than 80 years were more likely to have mortality after TBI than the younger cohorts, longer ICU length of stay, longer hospital length of stay. So, this is sort of the type of thing that we're kind of intuitively think of it and kind of get ingrained in us during medical school and residency and whatnot. And just, I don't want to belabor the point, but there's a lot of research that and literature that that they being older, these patients do have a higher mortality rate. Now, the question is, as I mentioned, why is that? Is it the age necessarily? Well, it's maybe not necessarily. The risk factors for mortality, one of the major things is cumulative comorbidities, right? Which is not, yes, as you get older, you may have more comorbidities, but then we also see patients that, are 70, 80 years old that are, healthier than the 50 or 60-year-old that we see coming to the hospital. So it's probably not, it's not just the age by itself. And then if you look actually at patients that are comatose and versus non-comatose, over half of patients that are elderly patients that come to the hospital that were not in a coma had a favorable outcome at 3 months, and 3 months is obviously a very short period of time. When we talk about outcomes after TBI, we really should be talking about a year or 2 years, really to see to what level patients are going to attain. And even at almost a quarter of comatose patients had favorable outcomes after that. So some of the predictors, so age does factor in. However, there are many other factors that factor into patients with the elderly TBI patients when it comes to influences on their outcome. And the injury severity is significantly more important than age by itself. Pupillary reflex, absence of those pupillary reflexes, when these are obviously factors that are contribute to outcome in younger patients as well. But then, comorbidities, how many comorbidities you have, and whether or not you're on antithrombotic therapy, those are also significantly important. And if you look at patients that are on anticoagulants and antiplatelets, and as I mentioned, 20% of these patients are, really it's specific ones. So warfarin, DOACs, and then patients, they don't have it necessarily here, but patients that are on dual antiplatelet therapy as well are more significantly affected. Whereas patients that are on monotherapy, particularly with aspirin, there's really very little evidence that significantly worsens their outcome by itself. So now, as people have looked more specifically in this age group, and I think, like the NASM workshop, as I mentioned, that you were, trying to get out of this nihilistic habit and looking what are the things that are actually driving outcome in these patients. We are seeing that, that older patients with TBI don't universally have poor outcomes. The poor outcomes are really in those patients that are the most severely injured, which would make sense, moderate and particularly severe TBI. And that actually by 6 months or so, a large portion, over, almost 2/3 or a little bit over 2/3 of patients that have um, mild TBI have good functional recovery. So if you come in and you're 70, 80 years old and you have a mild TBI, even if that needs surgery, you're very likely to do well long term, by 3 or 6 months after your injury. So really functional outcome and dependency after traumatic brain injury in the elderly population is really the burden of that is really more in the moderate and severe TBI. So this is just looking at follow-up at time points and the percentage of patients that have an unfavorable outcome. So you can see, like, right after the injury, yeah, even patients with mild TBI who are older are going to have, not have returned to kind of their functional baseline, but we wouldn't expect that necessarily. But if you give them time and you give them, treat them appropriately and hook them up with primary care and physical therapy and rehab, by 6 months and then definitely by 12 months, the vast majority of patients that had mild TBI have attained a good functional outcome. And the burden of the poor outcomes is still in those patients that are really severely injured. And this is moderate and severe, this orange one, this is severe. So you can see that it's really the severe TBIs that are in particular the ones that are driving that. And so that leads us kind of into frailty. And what we really are starting to think about more when we're talking about older patients with TBI, and that is assessing their frailty, which comorbidities are a component of, but it includes also other areas of a patient's kind of overall health. So what is frailty? So frailty, you should realize, is not a direct consequence of aging. In other words, you can be relatively old, you could be 70, 80, even 90 years old and not really be that frail. What it is, though, it's a intersection of somebody's chronic diseases and conditions. It does tend to increase with age, but just because you are older doesn't mean that you are frail necessarily. Frailty represents a functional decline that a patient has across multiple different systems. And there's many different kind of paradigms that you can use to assess and describe frailty. This is just one. This is one of them, and it's really across different domains. So there's kind of the physical domain in terms of chronic diseases and conditions. There's socioeconomic factors. So economically disadvantaged groups and ethnic minorities tend to have more frailty. It's more common in women, and really what frailty does is it makes a person more vulnerable to different stressors. And folks that are frail tend to be more likely to require hospitalization, have more complications, higher admission rates, and have higher mortality and unfavorable outcomes. And as I mentioned, there's many different ways to measure frailty. There's no kind of one that is everybody's coalesced around. And there's a lot of, now if you look in the literature, there's a lot of more kind of disease-specific frailty index. So there's like one for trauma that's a little bit complicated to calculate. There's other ones that have been tested and validated, and they look at different things, from number of comorbidities to different socioeconomic factors that would make somebody more susceptible to kind of have like a less of a reserve in order to basically accommodate different stressors. So frailty results, as I mentioned, in increased mortality and complications. And as I mentioned, there's no agreement really on a single score or index, and there's been many that have been developed. There's really a differential impact of frailty in mild or moderate TBI compared to severe TBI. So frailty is really more strongly associated with poor outcomes in milder TBI, and you can kind of the way that's been thought of or described or explained is that really the impact of frailty is probably more diluted in a more severe injury. In other words, if you have a severe enough injury, the injury itself becomes the major predictor factor of how you're going to do. But in somebody that has a milder injury, it's not really the injury itself that predicts how you're going to do. It's how frail you are. And again, these are just kind of different ways of thinking about how we can address frailty, assessing somebody's degree of frailty and then doing things to potentially make them less frail in terms of treating their comorbidities, or mitigating the risk that their frailty causes, so prevention of falls and things like that. So there was a study that looked at almost, little over 2/3 of a million patients, and looked at the impact of frailty on TBI outcomes. And you can see, again, they use what's called the MFI-5, which looks kind of like 5 kind of major indicators of frailty. What you can see is that basically the prevalence of frailty increased over twofold over a 10-year period. And maybe that's just that we're looking at it more, but this was looking at, it's probably more a factor of the aging population. There's increased odds of mortality, increased odds of decreased odds of a febrile discharge disposition if you're frail, and then increased odds of all these different things, like different complications, unplanned ICU admission, unplanned OR, increased ventilator days, et cetera, et cetera, et cetera. And other studies have come along and done systematic reviews and meta-analysis. I'm not sure if I don't think I put a slide in here for this, but if you actually look, if you go on PubMed and you type in TBI and frailty, and you look at how many publications, 10 years ago, there was no publications on TBI and frailty. Now there's about 50 or 60. So it's dramatically increasing. And people have been looking at frailty, particularly really started in ICUs a lot, looking at frailty, and then kind of general surgery. And now finally we're using it as a way to look at and control for outcomes in patients with traumatic brain injury, particularly patients that are elderly. But as I mentioned before, you don't need to be elderly to be frail. If you're 50 years old and you have a bunch of medical comorbidities and are socioeconomically disadvantaged, you could potentially be frail, even if you're not in that elderly population. So just the key takeaway for that is that age is just a number, and really even in patients with advanced age, it's really their frailty that is going to drive their outcome, particularly in patients that have less severe injuries. So let's switch gears a little bit and talk about management and treatment. So if patients are not necessarily destined to do poorly just because they're older, how do we manage and treat these patients? So the first thing that argues that really all patients that are older that have a traumatic brain injury should be treated at trauma centers. A lot of these patients, again, may have a head injury after what seems to be a relatively innocuous event. Maybe they trip, they fall, or they bump their head, but they're awake and they're alert, and they're taken to their local hospital, that isn't a trauma center or community hospital. There's a pretty robust evidence that patients' outcomes in this population that have a TBI are significantly better, and mortality is significantly lower when they are transferred and treated at higher level trauma centers, particularly level 1 and level 2 trauma centers. And that's been shown with, in this study with almost 20,000 patients, and it's been shown in other studies as well. Another study that showed that basically, even patients that are older that need surgery for a traumatic brain injury, a lot of these patients do well. And in fact, some of these even controlled for other factors, patients that need surgery, or patients that undergo surgery, I should say, when controlled for other factors, those patients will often do better than those that don't. So you can see here that basically craniotomy patients died at half the rate of non-surgical ones when they controlled for different other factors. And so really we shouldn't be so nihilistic about patients that need surgery, all other things being equal, and those patients that we take to the OR may actually do better than those that don't. It's really about just selecting and finding kind of that intersection between the risk of surgery versus the risk of them doing poorly if we don't operate. So we shouldn't be too nihilistic about surgical intervention in patients that elderly patients that have a TBI that then require surgery. If you look here, these are all significant, but these basically the odds ratio for survival in patients that underwent surgery when controlled for other factors, was again quite high for an epidural hematoma, which makes sense. An epidural hematoma, particularly if it's isolated epidural hematoma, those patients tend to do well, whether they're younger or older. Subdural hematoma was almost two times survival, same with brain contusion. So, when the factors that were associated with survival in this group did include, a lower overall injury severity score, higher GCS score, no coagulopathy, and operative intervention in these patients was directly associated with improved survival as well. So as I mentioned earlier, one of the kind of specific challenges in this patient population is dealing with the prevalence of anticoagulation and antiplatelet medication. Obviously, younger patients may be on anticoagulation for something, like a DVT or a PE or something, but it's much more common, obviously, for older patients to be on these medications for things like atrial fibrillation or antiplatelets for a prior stroke or some other indication. So, as I mentioned before, almost 1 in 5 patients in this patient population is on some form of anticoagulation or antiplatelet medication. And this is just kind of a list of all the different anticoagulant and antiplatelet medications that we see nowadays. As I mentioned earlier, warfarin and the direct oral anticoagulants and dual antiplatelet therapy tends to have the highest risk. So what does that leave? Well, basically that leaves aspirin and maybe Plavix monotherapy, but probably aspirin monotherapy does not seem to really be associated with an increased risk of TBI or worsened outcomes after TBI. But traditional warfarin, Coumadin, the new direct oral anticoagulants, and then dual antiplatelets all really do. They have higher rates of intracranial hemorrhage, higher rates of functional dependency, and higher mortality on those on antithrombotic therapy. There's also increased progression of traumatic hemorrhages. This, and as I mentioned before, not really associated with antiplatelet monotherapy. So this is just kind of assessing this. Again, the data on clopidogrel or Plavix is a little bit murky. Definitely seems that aspirin monotherapy is relatively safe. Plavix probably a little bit less safe, but then dual antiplatelet therapy definitely has a higher rate of hemorrhage progression and higher rates of mortality. And these are just kind of all belaboring the same point, but mortality is significantly higher in a dual antiplatelet group versus those not on dual antiplatelet or on single antiplatelet medication. So, over twice the mortality rate. And really what, all of these, the warfarin, DOACs, and the dual antiplatelet therapy are associated with an increased risk of traumatic hematoma progression, increased risk of neurosurgical intervention, and mortality. There are some studies that have shown that there wasn't a difference for mortality or increased hospitalization in dual antiplatelet therapy, but it did contribute to higher rates of neurosurgical intervention and hematoma expansion. So what about those patients that are on anticoagulation or antiplatelets that then have a head injury and have a negative CT? Are they at a higher risk of then having a delayed hemorrhage that we didn't see on the initial CT? Well, that risk is actually pretty low. Now, dual antiplatelets a little bit higher than aspirin monotherapy. So aspirin monotherapy quite low. If you have a negative head CT, it's going to stay negative. So there's really probably minimal need to repeat it. It is higher with dual antiplatelet therapy, 2 to 3%. So it's still not really, it hasn't reached the level where we typically will repeat it in all these patients, but it's not unreasonable to do so if you are really concerned that they may have an issue. More often what we'll do is we'll just watch these patients for a few hours, make sure that they're still doing okay, and then repeat it if they start having any sort of neurological decline or worsening symptoms. Again, direct oral anticoagulants the chance of them having a delayed hemorrhage is about 1.5%, and the percentage of those that are the percentage overall that is going to need neurosurgical intervention is exceedingly low. So again, we don't typically repeat the head CTs if they're negative initially. It's more that you just, if you observe them for a few hours and if they're still doing fine, it's very unlikely that they're going to have a clinically significant hemorrhage. So what do you do when a patient comes in on anticoagulation or on antiplatelets that does have an intracranial hemorrhage after a head trauma? Well, the first thing obviously is you want to discontinue it. I mean, that seems obvious, but you'd be surprised. So the first thing is to stop the medication. Don't stick them back on their home aspirin or their home apixaban, and then to reverse anticoagulation. So typically in traumatic brain injury and traumatic intracranial hemorrhages, you want to be relatively aggressive about reversing their anticoagulation. And that is because the chances of that hematoma expanding, again, this is not necessarily for aspirin monotherapy, but certainly for warfarin, DOACs, dual antiplatelet therapy, the risk of the hemorrhage expanding and the mortality risk probably in many cases outweighs the risk of reversing them. And I'll show some data showing that reversal on most patients is relatively safe. I would say that probably the ones that I would be the most concerned about reversing them is if you had just had a very recent, like clinically significant PE, or maybe a mechanical heart valve. Those are probably the two, or you have like a new traumatic blunt cerebrovascular injury. Anything that had just happened, that had just recently, then that's the reason why you're on anticoagulation, antiplatelet, that might give you a little bit of pause, particularly if you're reversing dual antiplatelet therapy. But by and large, anticoagulation with warfarin or DOAC should be reversed. And then in most patients with TBI, or a lot of patients with TBI, again, this is always a risk-benefit analysis between why you need to be on anticoagulation or antiplatelets and the injury that you had. But in many cases, it does end up being safe to resume these in a delayed fashion if it's necessary. And as I mentioned, it's key to decide to find out whether it's even necessary, because there's a lot of patients that come into the hospital. And I was actually just looking at a paper recently that Mike Hurley had sent to us about the percentage of patients that come in with a TBI, they're on unnecessary anticoagulation or antiplatelets is quite high. I think in the study it was around 25%. So when to restart is always we know we're going to stop it. We know more than likely we're going to reverse it. Then it's always like, should we restart it? And if so, when to restart it? And really this starts by reviewing the indication for the anticoagulation and the antiplatelet medication in the first place. Are you on it because you had a recent traumatic blunt cerebrovascular injury, or are we putting you on it now because you had a traumatic blunt cerebrovascular injury? And that's to prevent short and long-term stroke risk. Well, then you probably are going to need to continue it and keep them on it for a while. If you have a mechanical heart valve, you're probably going to need to put them on it again. I'll show some data that it's really probably safe to leave them off of anticoagulation for up to a week, even with a mechanical heart valve. Tissue valves, you can also obviously leave them off longer. If you've had a recent PE or DVT, if you don't, that's probably somebody that you're going to need to restart anticoagulation on relatively soon, particularly if PE was significant enough, that they had, hemodynamic instability or anything like that. It's somebody that you might, again, probably you're going to potentially reverse them if the hematoma is significant enough, but you might want to think about that might be a person you want to start back on anticoagulation relatively early once the hematoma is stabilized and whatnot. Similarly, if you've had a recent MI, you might need to start them on antiplatelets relatively soon. Drug-eluting cardiac stents, again, we see a lot of patients that come in on either antiplatelet monotherapy or still on dual antiplatelet therapies after 12 months. And, you really only need 6 to 12 months of dual antiplatelet therapy. So again, we see a lot of patients that come in that don't necessarily need to go back on their antiplatelet medication. Similarly, stroke, atrial fibrillation, again, oftentimes the day-to-day risk of having a stroke after atrial fibrillation is relatively low, particularly compared to the risk of hemorrhage expansion and poor outcome from not reversing it from their after a TBI. And so really all these, it requires, pretty intricate, thought process in terms of what is the risk of doing poorly if we don't reverse it, or if we restart it, or if we don't restart it, versus, the risk of having a sequelae from not restarting the anticoagulation or antiplatelet therapy. And so people have started to look at this in a more kind of rigorous fashion. And there was an Italian European consensus document on the management of antithrombotic medications and what to do in patients with isolated TBI. And basically they divided up, basically different risk stratifications. This is like low bleeding, low thrombotic risk, low bleeding, high thrombotic risk, and they defined, what those were in their document. And basically then went through, okay, what are the different, if you say, so, hey, have a high bleeding risk with a low thrombotic risk, what treatments are appropriate? So it's appropriate to stop, warfarin using PCC, and or if it's appropriate to attain an INR of less than 1.5. So they kind of use this as a schematic of what to do and when to do it. This is at Elmhurst, this is our early anticoagulation, antiplatelet reversal after trauma protocol. So you can see, we determine, the indication for the emergent reversal. We determine what the agent is, and then we use that to guide what we're going to use to reverse patients. And oftentimes, for the direct oral anticoagulants, there is different specific reversals. You might not necessarily have that. So like you might not, for Pixaban, for instance, you might not have Andexanet, in which case, 4-factor PCC is usually the second line therapy for that. And that's what we use at Elmhurst a lot. So I won't belabor this point, but generally speaking, you will want to reverse patients in most instances. This is just another schematic showing kind of the amount of 4-factor PCC we use to reverse these patients. So patients that are on DOACs that have life-threatening bleeds and intracranial hemorrhages or traumatic-induced coagulopathy, so that spontaneous ICHs or trauma-induced hematomas, we want to make sure we're giving them the highest dose, really, of 4-factor PCC, which is 50 units per kilogram. So we often give them 2,000 units right off the bat, and then we'll calculate the remaining dose that we need to give them to make sure that they're fully reversed. And as I mentioned, one of the first things we're thinking about is it safe to reverse these patients in the first place, particularly if they've got, presumably have an appropriate indication to be on anticoagulation or antiplatelet therapy. And most of the studies have shown that, yes, it is safe to reverse these patients in most instances. And so this was a meta-analysis of 15 studies that looked at anticoagulation reversal using 4-factor PCC for emergency neurosurgical procedures, just kind of all procedures, not just TBI. And basically they found that there was no significant difference between using 4-factor PCC and FFP for reversal. No change in mortality, no change in thromboembolic incidence. And as I mentioned, there are some specific reversal agents, in particular Andexanet. It's kind of notorious because how expensive it is. There have been studies that have compared that against 4-factor PCC, and I know this is an area of contention, but there are quite a few studies that throw into question whether or not Andexanet is significantly better than 4-factor PCC, and then there are some conflicting studies that show that Andexanet may be more effective than 4-factor PCC for DOAC reversal. So I think the jury's still a little bit out on that. So in terms of antiplatelet medication, and particularly, as I mentioned, aspirin monotherapy, as I showed before, the risk of progression of somebody's TBI and mortality after aspirin monotherapy is not nearly as high as for dual antiplatelet therapy. There's oftentimes we may use desmopressin or DDAVP, or platelet transfusions to reverse patients on aspirin monotherapy. There's really very little evidence that either of these things help significantly. Our paradigm at Elmhurst is really to give desmopressin for antiplatelet reversal in most cases. And then we reserve platelet transfusions for patients that are going to need neurosurgical intervention or that have thrombocytopenia. And that is because desmopressin is relatively innocuous. Whether or not it's effective or not is pretty up for debate. But there's very few patients that have complications from getting a desmopressin, a dose of desmopressin at 0.3 micrograms per kilogram. Giving it platelets, obviously you want to give platelets when you need it. As I mentioned, we give it when somebody's going to need neurosurgical intervention or if they have thrombocytopenia, but we don't typically give it upfront with the desmopressin to reverse antiplatelets, patients on antiplatelets. Where we do it, even if they don't have neurosurgical intervention or thrombocytopenia, and I should have probably put that on here, is this: if we give them desmopressin and then they still, on a repeat scan, have a worsening hemorrhage, then we'll probably consider giving them a platelet transfusion because the desmopressin didn't work in and of itself. I do mention thrombocytopenia here because this is probably an under-recognized, at least, a lot of the times with, maybe failed to be reported by the attending or other allied health professionals about, what the platelet level is. But thrombocytopenia is a very significant risk factor for poor outcomes after TBI. So a platelet level, and again, different studies have used different platelet levels. A lot of the times, a platelet level of 150,000 per cubic millimeter is kind of the threshold. In most neurosurgery literature or how we've been trained is that we use like less than 100,000, at least in terms of when it's the level we want it above to do a neurosurgical procedure, ideally. But 150,000 is kind of the more common threshold. But thrombocytopenia below that level is a risk factor, independent risk factor for hemorrhage expansion in severe TBI. And thrombocytopenia is also an increased risk for needing neurosurgical intervention and mortality. And under 100,000 is also an independent predictor for mortality. So you do want to take into account the fact that patients that have thrombocytopenia need that thrombocytopenia treated with platelet transfusions to try and get their platelet level into a more normal level. And then a lot of patients that have thrombocytopenia, obviously their platelets are also, they have a qualitative defect often that we can detect using TAG and platelet mapping. So again, DDAVP in animal studies and some human studies have been shown to improve bleeding time and increase platelet aggregation, but there's there's less evidence in terms of its effectiveness in actually treating patients and reversing antiplatelet therapy using it. So again, large number of patients, particularly elderly patients that are on aspirin, reversal of antiplatelet therapy with both DDAVP and or platelet transfusion didn't improve survival in severe TBI. And there's a lot of other studies and meta-analyses that have looked at this that have shown that antiplatelet reversal, even using platelets, doesn't tend to alter the risk of expansion or their mortality. So that's part of the reason why we usually don't jump to giving platelet transfusions right off the bat in order to avoid the risk of reactions to the platelet transfusions, and we'll just stick with DDAVP, even though, again, DDAVP, we're not sure how effective it is, but at least it's not as likely to cause problems when you do give it. So again, this is just kind of flavoring the fact that it kind of touches the null value here, so as well in terms of giving platelet transfusions after intracranial hemorrhage. And if you actually look here, this was the patch trial. This is spontaneous hemorrhage, where they did show that at least in this patient group, that the odds of death and dependence was higher in patients that got platelet transfusions. Now, obviously not directly comparable to patients with TBI, and this study also really only included small spontaneous ICHs and less high risk ones. Their median volume was 13 millimeters, so it's milliliters, so it's not applicable necessarily to all patients, but this is sort of what we're trying to avoid by kind of minimizing platelet transfusions to those patients that really need it. So in terms of resumption of anticoagulation and antiplatelet medications, again, I mentioned it's really a balance of the severity of the TBI, the bleeding status, and the need for anticoagulation or antiplatelet medication. There was a study with over 100 patients, over 170 patients, that showed that withholding anticoagulation, even in patients with had mechanical heart valves, that it was safe for basically up to a week. So, reason why I mentioned that is because we often think of patients with mechanical heart valves as having some of the highest risk for thrombotic complications from withholding their anticoagulation, but probably holding it for at least 7 days in that patient population is probably safe. So I would say, for me at least, it's really the patient that that has had like a recent PE, where I'm most concerned about probably getting it on sooner than a week. This was looking at resumption of direct oral anticoagulants in patients with atrial fibrillation after a traumatic hemorrhage. And many of these patients were started, almost a month out, and they had one patient with a recurrent hemorrhage and one patient with an embolic stroke that had been off of it for 118 days. So, they were holding it for quite some time. We looked at our patient population at Elmhurst. We actually found 10 patients where they'd had an acute traumatic brain injury where they either needed to be resumed on anticoagulation, specifically with apixaban, or we needed to start them on anticoagulation, and the anticoagulation that we chose was apixaban. And the reason why we've kind of coalesced around using apixaban when it's appropriate for the indication, for when it's an appropriate medication for the indication of for needing anticoagulation, which it isn't always. So mechanical heart valves are one where apixaban is not sufficient to use. You have to use warfarin for that. But one of the reasons we've coalesced around using apixaban is that apixaban in the studies looking at patients that had complications from anticoagulation, the patients with apixaban tended to have less spontaneous intracranial hemorrhages. And so the thought is maybe then it is also safer to use apixaban in TBI patients. So we're kind of extrapolating that based upon no real good literature, but not many people have looked at this. And so we looked at 10 patients that we started on apixaban or resumed apixaban after their TBI. The time from their first stable head CT to when we started apixaban was about a week. Some are less, some are longer. The ones that we started earlier tended to be patients that had a new indication for anticoagulation. So patients in particular that had a DVT or a PE that then needed to get put on anticoagulation relatively soon. So those tended to be the patients that we started earlier on apixaban, and patients that were getting resumed typically for AFib or A-flutter tended to wait about a week or slightly longer than a week to restart it. We follow these patients out for an average of about a month. No patient had any new or worsening hemorrhage after starting apixaban. No patient had needed to undergo neurosurgical intervention. We did have 2 mortalities out of that were unrelated to the apixaban. So at least in this very small cohort of patients that we looked at, we have not had any issues when restarting a patient on anticoagulation with apixaban after a TBI. So I'd be remiss in the last few minutes if I didn't touch on subacute and chronic subdural hematomas in this patient population, because as I mentioned, this is rapidly becoming the most common neurosurgical disease that we treat as neurosurgeons, and it is going to only become more common as time goes on. And so for those medical students and others that are joining us, these are just some pictures of an acute subdural hematoma, and you wouldn't just leave this one. You would either treat this, or this patient's probably going to potentially expire from this. So this would be a situation where we either treat them, or their goals of care may be that they don't want to undergo aggressive intervention. But if you were to leave a subdural hematoma and let it chronify, eventually it will become a subacute subdural hematoma, and then it may eventually become a chronic subdural hematoma. And really, without getting into it too much, really subacute and chronic subdural hematomas are really this pro-inflammatory disease or situation where the hematoma that was originally there develops these membranes around it, and these membranes have neovascularization that occurs. And then if the balance or the homeostasis of is more towards these membranes being leaky and developing more fluid and more inflammatory components, and if the homeostasis is such that is outweighing the reabsorption of that fluid, then that hematoma is going to persist and potentially get larger with time. Whereas, if the homeostasis or the balance is towards reabsorption outweighing the leakiness of the membranes, then eventually the hematoma will probably reabsorb and go away on its own. And so, we often see these patients come in. They may have had a trauma that they knew about, and we've seen them before in the hospital, and they had a very small subdural, but more commonly, these patients don't even remember the trauma that they had. It might be a relatively innocuous event or event they can't even remember, and they come in with these, oftentimes with hemiparesis or altered mental status, and then they have a subacute or chronic subdural hematoma. And then also they can develop, because they have these neomembranes and these neovascularization, these blood vessels are not normal. They can have acute hemorrhages into a chronic subdural, and so have an acute on chronic subdural hematoma. This is just a picture of what these membranes kind of look like around these. So these often were classically treated either with at the bedside with burr hole drainage, or in the OR with a burr hole drainage, or maybe a small craniotomy like you see here. And really, and then the other treatment has for non-surgical treatment has been dexamethasone. The main issue with these is that the recurrence rate typically and classically has been very high, upwards of 20% in these patients. And if you look at dexamethasone, Peter Hutchinson from the UK, he's done a lot of kind of pragmatic randomized studies in TBI. They looked at chronic subdural hematomas, and they looked at dexamethasone versus placebo, and they showed that while the patients on dexamethasone, their subdural hematoma did resolve radiographically at a higher rate than those patients on placebo, patients did worse. They had more serious adverse events and worse outcomes. So, favorable outcome in 84% versus 90% on placebo. So basically the treatment was worse than the disease in this case. So they needed less surgery in the dexamethasone, but on the whole, they did worse. So dexamethasone really is kind of, we typically now only use it if a patient, has no other option really. And as I mentioned, classically surgical management for chronic subdural hematomas has been either twistocraniostomy, so that's like a bedside burr holes in the OR, or craniotomy. But the recurrence rate has been high, upwards of 20-30%, depending upon kind of the modality that you used. So the new treatment that has come about in the last 10 years that is rapidly gaining more and more kind of acceptance and penetrance in the neurosurgical arena is really using neuroendovascular procedures with these liquid embolics, typically to perform middle meningeal artery embolization. And the theory is that by embolizing the middle meningeal artery, you're decreasing the blood supply to these neomembranes, and therefore causing them to be less leaky, causing them to be less likely to hemorrhage, and tipping that balance, that homeostasis, towards the reabsorption standpoint. And so you can see here that in patients that got surgery plus MMA embolization, the recurrence rate was 4% versus over twice as much higher rate of recurrence if they only had surgery. And so relative risk factor of recurrence of basically 1/3 if you added MMA embolization as an adjunct to draining. And then there's additionally a population of patients that may not need drainage of their hematoma with surgery initially, and maybe be able to be treated primarily with middle meningeal artery embolization to prevent it from getting larger, to prevent it from them needing surgical intervention in the first place. So you can see here at Elmhurst, kind of our paradigm over the last 10 years has been, we've had an increase in using SEPS, which is subdural evacuating port system, which is a bedside way of draining the subdural hematomas. And one of the advantages of SEPS is it allows us to avoid general anesthesia more often, has, I think, one of the results in less pneumocephalus, which I think then doing burr holes or a craniotomy, which I think is an underappreciated factor that leads to patients with altered mental status after surgery. We've all seen it where you get drained out the subdural hematoma with burr holes or a craniotomy, looks great, but then they have a ton of air intracranially after, and that air there's a couple negative aspects of that. One is that can cause delirium in and of itself and altered mental status. Additionally, that air can actually prevent the brain really from expanding up as quickly as it otherwise would, which then kind of creates a potential space for fluid and a hygroma to develop. So I think, my theory is, at least, I don't have any literature to prove this, but that in SEPS there's certainly less pneumocephalus that we see, and in fact it's quite profoundly less than if you look at burr holes or craniotomy, and that reduction in pneumocephalus is probably leading to kind of more rapid improvement in the mentation of a patient that gets SEPS versus a patient that has burr holes. It's hard to kind of control for the effect of general anesthesia and that, or less anesthesia, but and that also that their brain potentially will expand up more quickly. So we've tended to use SEPS more and more, and then particularly as middle meningeal artery embolization has come on the scene, we feel more confident with using SEPS to drain it, because we now know that we can then use MMA embolization as an adjunct to that, and then probably dramatically improve the rate at which the subdural is going to resolve and not recur. And by doing those two things in combination, it really allows us to avoid these elderly patients getting general anesthesia, avoid a more kind of significant need for significant neurosurgical intervention. And then, if a patient either is not really appropriate for SEPS, so they have a ton of membranes or whatnot initially, or they have a recurrence, then we'll take them to do burr holes or a craniotomy if needed. And then, so I just wanted to circle back to the slide we had at the beginning, that, in older patients, traumatic brain injury, it's now no longer, this minority population, this niche population. This is the face of traumatic brain injury now, and it's going to only become more so in our lifetime. Over the rest of my career, elderly patients are going to be the most common patients with traumatic brain injury that we treat. So we really should be investing more in research in this area, looking more at what the impacts of different comorbidities or different factors, frailty, and how that impacts patients' outcome. One of the things I want to do is actually look at patients with different levels of frailty and different severities of TBI, and see, where's that intersection? Where's between a patient that gets surgical intervention, the one that doesn't? Oftentimes the decision we're trying to make is, I have a 85-year-old in front of me that has these medical comorbidities or frailty with, maybe this, and they have this hematoma. Is that patient going to do better if I operate on them or not? There's risks to surgery. Sometimes when we operate on these patients, they then have, seizures or status epilepticus. The older brain is a little bit less resilient in some ways, and so we've had patients that had potentially cortical spreading depolarizations and then just don't wake up after general anesthesia as rapidly. So I think really kind of finding out and developing a model where you could plug in some of that data and basically say, the risk of doing surgery in this patient is actually significantly less than the risk of if we leave it alone. Or a better way to put that is, this patient is much more likely to have a favorable outcome if we operate, because as I mentioned, in some studies, it's been shown that if, kind of all things being equal, if you have an operative lesion, and even in patients that are older, surgery is the way to go in those patients. So I think, more research on that, more research on ways that we can modify factors that will help improve their outcome are significant. And I don't have it on here, but some of those things are as simple as there's data to show that in older patients, if they use some sort of walking assist device like a rolling walker or cane or some sort, that reduces the chances of a head injury by 50% if they fall, even if they let go of it. So presumably because the fall, it's not gonna be as unprotected a fall. It's not gonna have the same degree of force associated with it. So something as simple as that, something as simple as making sure all these patients are hooked up with primary care and are seeing a physician and rehab and physical therapy after a TBI like this can make a significant difference in how they do long term. So those are kind of the main key points. I wanted to just highlight a couple others that, as I mentioned, TBI is really now a disease of older patients. I think it's important to realize that the TBIs in older patients, many of them are from low energy injuries, so fall. So you should always be suspicious, particularly if you're elderly, and if an elderly patient has a fall or somebody's on anticoagulation or antiplatelet and they have a fall, always suspect that they could have a TBI, because oftentimes it's a low energy injury, and the degree, even the low energy transfer does not seem to be predictive of the TBI severity. In other words, you can have a pretty significant TBI, moderate or severe TBI, or a pretty significant CAT scan in a patient that has a relatively innocuous mechanism. And patients that are older, that is much more likely that they will have a more severe TBI for the same degree of energy or same mechanism as somebody that was younger. Again, most patients with an elderly TBI with a positive head CT should really be treated as a trauma center because they do better. Frailty is more important than age. And then operative TBI patients, even those that are older, often do well, particularly those that with mild TBI. So thank you. Thanks. It went a little bit over, but there's still time for questions if anybody has any.
Yeah, thanks, Zach. That's a great talk, and you can see how much experience you have with this like increasingly complex disease. I just had a question about how you personally, with all your experience, like process the evolution in terms of how we perceive how frail these patients are, right? Like when we were training, if somebody was 80, that was
Yeah.
bad. If somebody was 60, that was good. But obviously,
Yeah.
appreciate more and more
Yeah.
how much more complex that is. And without, I guess, getting too deep into, the unseen future where the EMR's AI will just tell us whether or not we should do an operation. We still have to do some of the decision making ourselves on these patients that are, very frequently sort of in the penumbra about should I operate, should I not operate? Is this a goals of care patient, or should we pull out all the stops? Is there any one disease process or comorbidity or any factor on which your thinking has evolved, like in the last 10 years or so? I mean, we all have our bugaboos, right? And I
Yeah.
get worried about renal failure, that just kind of sends
Yeah.
shivers on my spine. Is there
Yeah.
anything that maybe you'd be surprised, like 10 years ago, you'd be surprised by in terms of what you really prioritize now?
Well, it's funny because you mentioned that because that was the exact disease process that I was thinking. So I was thinking, renal failure, particularly patients on hemodialysis, obviously they tend to do in general, that's one that always gives me pause. Part not so much necessarily the renal disease, but like the coagulopathy that they have associated with that. It just makes everything significantly worse. And then, I mean, I would say, I just kind of answering your first question first is that, I think that's ideally that's where we'd be heading, where like, how like in Epic, there's like their decompensation index. It'd be nice at some point if there's like an automatically calculated frailty score. Again, all the frailty index that we use are kind of like retrospective right now, right? We're not doing it in real time. We're not basically being like, okay, this is a patient, let me calculate their frailty index. I think that's eventually the way we're going to be heading. Part of the issue is like depending upon which frailty index you use, they can be relatively complex to calculate. Some of them, like the trauma specific frailty index, for instance, you actually have to talk to the patient and talk to their family and figure out some of the things that aren't in like their medical record usually, right? Some of them are relatively simple to do because they're just adding up their comorbidities, but it's probably probably the better ones are like looking at like, okay, like how many times did this patient fall in the last month, right? Like that's like one of the things that's in the trauma specific frailty index. Have they injured themselves when they had a prior fall, things like that. So it will be nice at some point if we can get something that we can use kind of more in real time. And then I think you kind of hit the nail on the head. We need to do studies where we then are using a model like that, basically, where we're then calculating, okay, I have this patient before me. I can, either the Epic or can do the calculation for me, or I can put it into like, MedCalc and calculate it in like 2 seconds. And then I can put that in, and I can put that into a model and basically be like, this is the chances that this person is going to, be functionally independent at 6 months if I operate on them versus if I don't, right? And if it's higher with surgery, then now I have some objective data where I can be like, okay, you're probably going to be do better if I operate than if I don't, but I think that's going to require, it's going to, that'll hopefully come at some point. But that's sort of one of the studies that I would like to do would be, in a little bit more rudimentary form would be, as I mentioned, would be, kind of categorizing patients based upon, their abbreviated injury score, right? So you have to control obviously for the severity of the injury that they have, and then look at different frailty scores and look at patients that got treated operatively versus those that didn't get treated operatively, and see where that intersection is between their chance of survival and their chance of a good functional outcome is higher when it's where that crosses. If it's higher at all stages of all different frailty levels at that same injury severity score, then okay, that's then you should do surgery in kind of all those patients. But so I think that's kind of where we're headed. We have that for other things, but we don't have that for TBI yet, certainly.
Oh, great, thanks.
Yeah.
And we've got a question from our director of neurotrauma at Mount Sinai Morningside about DNR DNI status. I'll just read it verbatim. Great talk. Do you think there is an influence of pre-admission DNR DNI status on outcomes after TBI in the elderly population? Meaning DNR DNI status casting a more negative prognosis and leading to a worse outcome from less TBI treatment when controlled to the same population without these orders.
Yeah, I do. I don't have the references off the top of my head, but I'm pretty sure if I remember correctly, that's been shown in multiple different disease states, but also TBI. That like if somebody has a DNR or DNI order and pre-existing status, that those patients tend to do worse, largely because we treat them differently. Obviously there's going to be some patients that do worse just because if they already are DNR, DNI, maybe they're more likely than to have further goals of care discussion when they're in the hospital and decide not to be treated or whatnot. But DNR, DNI doesn't mean don't treat me. It just means don't resuscitate me if my heart stops, and don't stick a tube in my throat to treat me. But it doesn't necessarily mean don't treat me. And then some of those patients oftentimes, when push comes to shove and they have to make a decision, or their family makes a decision, they opt for treatment and to reverse at least the DNI part of it often. But I'm pretty sure that there is data out there to show that those patients that it does independently factor into how those patients do. Now I'm obviously not saying that we should in patients that have goals of care that or advanced directives, things like that have been there, they definitely don't want heroic measures taken or aggressive measures taken, that we should we obviously need to keep that in mind and abide by that, and do what the patient and the family ultimately wants. But I think we also need to be careful about the fact of It's just saying that, you know, just because you're older, you're going to do worse. That's not necessarily the case. It's really the patient that has significant medical comorbidities that's more likely to do worse because of those medical comorbidities, not necessarily because of the TBI in and of itself.
Great, thanks.
Yeah.
It looks like no more questions, so I think we'll bring it to a close. Thanks again, Zach, for a
Right.
spectacular talk.
All right. Thank you. See everybody in a couple months again for our next one. All right. Have a good day.